This is Kim Burchell from the Oregon Health Sciences Department of Neurological Surgery. I want to review with you trigeminal radiofrequency gangliolysis in the treatment of trigeminal neuralgia. This is an important technique for a number of reasons, including its efficacy and accessibility for patients. It also represents an alternative to microvascular decompression, or MVD, when this procedure is not appropriate, such as in the very elderly patient or those with symptomatic trigeminal neuralgia from multiple sclerosis. The first step in treating facial pain is accurate diagnosis. Using a procedure for the wrong diagnosis leads to poor surgical outcomes. About 20 years ago, we developed a simplified classification of facial pain, which has proven to be a useful method of thinking about this problem. Trigeminal neuralgia is defined as pain of spontaneous onset. If the pain is mostly episodic in nature, we classify this as trigeminal neuralgia type 1, or TN1. This diagnosis is essentially synonymous with classical trigeminal neuralgia. If the pain is mostly constant, we deem this to be type 2 trigeminal neuralgia, or TN2. This diagnosis overlaps with what some call atypical trigeminal neuralgia. If there is a history of incidental prior nerve injury, whether it be accidental or surgical, the pain is called trigeminal neuropathic pain, or TNP. If the pain was the result of intentional trigeminal nerve injury, for example from trigeminal rhizotomy, the term is trigeminal deafferentation pain, or TDP. Sometimes patients with multiple sclerosis develop what otherwise has the same characteristics as TN1, but in this case it is symptomatic trigeminal neuralgia, or STN. In older patients, an outbreak of acute herpes zoster in the first and second divisions of the trigeminal nerve can lead to chronic trigeminal postherpetic neuralgia, or PHN, in these distributions. Lastly, in a small minority of patients, psychological conditions can produce atypical facial pain, which must be substantiated by a psychologist interview and neuropsychologic testing. This video will focus on the treatment of TN1. One aspect of TN1 which bears emphasis is that it is a progressive condition. Early on, pain-free intervals are more common, and the pains are more readily treatable with anticonvulsant drugs. As the disorder progresses, pain-free intervals disappear, and the pain becomes more medically intractable. This progression is exemplified by a patient's diary of his TN1 extending over several years. This slide shows the patient's addition of medication including gabapentin, duloxetine, ibuprofen, and loratadine with progressive pain over those years. In this chart from the same patient, you can see the increasing frequency of TN1 pain over a 5-year period, with the latest year represented in green. We will now turn to the surgical treatment of TN1 with a focus on radiofrequency lesions. Structured Cochrane analysis of surgical procedures for TN1 shows that the most long-lasting procedure is MVD, although there is a steady pain recurrence after that procedure of about 5% of patients per year. Gamma knife radiosurgery is said to have a median recurrence rate at around 4 to 5 years, although in the radiosurgical literature the definition of pain relief is much more inclusive than that of the surgical literature. Glycerol rhizolysis tends to have a relatively rapid pain recurrence on average at around 2 to 3 years. Radiofrequency lesions produce class 1 pain relief, that is, no pain and off medications, lasting 4 to 5 years on average. The Hartle technique for accessing the trigeminal ganglion and cistern is well established, but it requires a degree of technical proficiency to avoid complications or unsuccessful procedures. Under deep sedation and with fluoroscopic imaging, a radiofrequency electrode trocar is inserted from a point about 2.5 to 3 centimeters lateral to the corner of the mouth and 1 centimeter below the occlusal plane of the teeth. Two other landmarks to incorporate are first a point 2.5 centimeters anterior to the ipsilateral tragus, and second, the midpoint of the ipsilateral pupil. The index finger of the operating surgeon is inserted in the mouth lateral to the teeth to ensure that there is no penetration of the mucosa intraorally. The needle is directed in the submucosa, taking care to avoid intraoral penetration. The needle must be passed medial to the coronoid process of the mandible to achieve the skull base anterior to the foramen ovale. The ultimate direction of the needle is represented by the line of intersection of a plane from the entry point to the point anterior to the ipsilateral tragus and the plane from the entry point to the ipsilateral pupil as shown in the diagram. Once the skull base anterior to the foramen ovale is acquired and verified by fluoroscopy, the needle can be advanced into the foramen ovale as will be subsequently demonstrated. It is worth noting at this point that advancing the needle through the foramen will first achieve the third division of the ganglion, whereas with further penetration, access to the second and first divisions may be accomplished. Fluoroscopically, I use a submental vertex view to confirm penetration of the foramen ovale and to avoid a more posterior placement of the needle, which risks injury to the carotid artery through the foramen lacerum. I also find that the foramen spinosum may be more easily visible than the foramen ovale and serves as a useful landmark, particularly in older female patients with osteoporosis. The high heel footprint of spinosum and ovale is visible in most cases. Penetration of the foramen ovale is often accompanied by a small, palpable jaw jerk reflex. At this point, I move to a lateral fluoroscopic view to assess the depth and angle of needle penetration. It is important to ensure this projection is straight lateral to make this assessment, using the internal auditory canals, orbital roofs, and planum sphenoidale to rectify the view. An electrode with a curved tip can be used to acquire more medial divisions as shown in this view. The equipment required for this procedure is straightforward, consisting of a stimulator RF generator, an electrode set including straight and curved electrodes, and a fluoroscopic unit. As I mentioned earlier, RF lesions will produce a good outcome lasting an average of 4 to 5 years. I believe that one of the keys to the performance of this procedure is patient amnesia. If patients have a negative experience, they are unlikely to wish to perform this procedure again in the future, which is likely to be necessary in many of these cases. We perform needle placement with the patient under brief general anesthesia, inserting a nasal trumpet to allow some control of the airway. Once the needle is inserted, the patient is allowed to recover to the point of responsiveness, whereupon electrical stimulation produces paresthesias in the appropriate division. At this point, the RF lesion is created with the patient again briefly anesthetized. The patient is awakened again, and the receptive field of the appropriate division is tested for loss of pinprick sensation. If hyposthesia to pinprick has been achieved, the patient is awakened fully and the procedure is concluded.
Yes, I need a little monitor on his arm here. Okay.
Let me know when you want to start filming.
So, and that's kind of our position right there. My finger's in the mouth, I know I'm not through the mouth. And I'm aiming at a point about in the medial pupil, and I'm also aiming at a point about an inch in front of the ear. And the intersection of those two planes determines the line of the needle. So that should be pretty close, x-ray wise.
During the RF lesion, it is common to observe a skin flush over the divisions of the nerve that are injured by the electrode heating. This can be seen directly, as in the upper right of this slide, or by thermography, as shown in the upper left, in this case in the first and second divisions. We have previously investigated the physiology of trigeminal neuralgia using microelectrode recording. This was done via the RF electrode trocar during a lesioning procedure. The microelectrode can be seen on this fluoroscopic image. Action potentials from the large ganglionic cells could be recorded and the receptive fields mapped. Abnormal spontaneous action potential bursts could be recorded. In 2 patients, though, we were able to produce very high-frequency discharges from the ganglion by touching the skin of the patient's usual trigger area. These after discharges lasted about the same length of time of the patient's typical pain, then subsided and could not be further triggered for several minutes after the episode. These discharges were similar to those we have recorded in animal models of trigeminal neuralgia, shown on the left. We believe these findings support the leading hypothesis for the origin of trigeminal neuralgia proposed by Rapport and DeVore in 1994. They theorized that an abnormal high-frequency discharge in a single fiber of the trigeminal nerve would cause the release of neurotransmitter in the ganglion, producing a chain reaction resulting in an overwhelming spike of pain sensation in the patient. If this theory is correct, we believe that the trigeminal RF lesions work by interrupting the transmission of this abnormal discharge in the trigeminal nerve root to the ganglion. This would eliminate the chain reaction at the level of the ganglion and prevent the spread of the pain. I'd like to conclude this with an intraoperative video illustrating many of the features I have described for the performance of an RF lesion for trigeminal neuralgia. First, the patient is placed supine on the OR table and a fluoroscopic submental vertex view of the skull base is obtained. The foramen ovale and foramen spinosum are then identified bilaterally.
Lateral to the corner of the mouth, about 1 centimeter below the plane of the teeth. Put one finger in the mouth just to prevent me from getting into oral. Okay, again, staying submucosal and then medial to the coronoid process to the skull base. So let's fluoro. Should be really close. I can barely see the foramen. Oh, there's a jaw jerk. Okay, we're in great shape. Okay, so what you see on the lateral is the clivus here and the petrous bone here. They form an X with the nexus of the X right there. If you're pointing right along that plane, you're pointing right straight down the 3rd division. As you move away from that, you're pointing more and more toward the 2nd and 1st divisions. So I like the fact that this needle is going up, more pointing toward the sella than the clivus and more toward the dorsum sella there.
Typically, lesions at 80 to 90 degrees centigrade for 90 seconds are created. A skin flush in the affected divisions can occur.
Any difference between those two, number 1 and number 2? They're about the same.
In this video session, I've attempted to lay out what I believe are the principles and procedures of trigeminal radiofrequency lesions for the treatment of trigeminal neuralgia. This procedure is very effective and can be repeated if necessary. It does require knowledge, skill, and experience, but it is a rewarding way to relieve the pain of trigeminal neuralgia in those patients unfortunate enough to develop this condition.